Welcome to the Journal of the American Society of Echocardiography podcast. Editor-in-Chief Dr. Michael Picard, Managing Editor Deborah Meyer, presented by myself, Dr. Amer Johri. This version of the podcast is an audio long read, and I will be narrating 3 short articles from the November 2020 issue of the journal. The first article is entitled Point-of-Care Ultrasound Findings and Clinical Outcomes in Patients with COVID-19. To the editor, POCUS has been increasingly used for the efficient detection of cardiorespiratory complications of COVID-19. Cardiac POCUS may have similar benefits to transthoracic echo while decreasing staff exposure to patients with COVID-19. Cardiac POCUS has utility with up to 50% of patients with COVID-19 having cardiac abnormalities on echo, leading to management changes in nearly 1/3. POCUS of the lung enables diagnosis of pathologies such as alveolar consolidation and alveolar interstitial syndrome. The relationship between POCUS findings and COVID-19 outcomes is unknown. The aim of this study was to identify how lung and cardiac POCUS findings in patients with COVID-19 relate to clinical outcomes. We retrospectively reviewed lung and cardiac POCUS studies performed in patients with COVID-19 and suspected cardiorespiratory involvement at the time of presentation to New York hospitals between April 1, 2020 and May 15, 2020. POCUS was performed by certified emergency department physicians. Lung POCUS was used to identify the presence of A and B lines as shown in Table 1. Cardiac POCUS was performed according to the ASC recommendations. The study cohort was divided into those who did, Group 1, and who did not, Group 2, develop the primary outcome of death or need for mechanical ventilation. Patients in Group 1 were older, with a median age of 73 years versus 62 years, but cardiovascular disease risk factors were similar between the groups. All lung POCUS examinations were interpretable. Among cardiac POCUS studies, 99% and 88% had suitable imaging for LV and RV assessment, respectively. Lung POCUS findings in the 2 patient groups did not differ, with B lines being prevalent in both groups. Lung POCUS has limitations in COVID-19 and may not detect centrally located consolidation from bacterial superinfection. With cardiac POCUS, Group 1 patients had a higher incidence of reduced LV ejection fraction, 37.9% versus 16.2%, with a p-value of 0.045. Sood et al. Have shown that acute LV systolic dysfunction was present in approximately 20% of acutely ill patients with COVID-19 and was due to myocarditis, stress-induced cardiomyopathy, or coronary thrombosis. In the present study, it is possible that patients had pre-existing LV dysfunction unrelated to COVID-19. Cardiac POCUS has a critical role in the management of patients with COVID-19. Our study showed that cardiac POCUS may risk stratify acutely ill patients with COVID-19 on the basis of LV function and identify patients with pre-existing or new LV dysfunction who are at higher risk for adverse outcomes. The incidence of abnormal RV findings was lower than in prior studies. This may be explained by POCUS evaluation early in the clinical course before further development of factors known to precipitate RV pathology, including pulmonary embolism, progressive lung infection, hypoxia, and mechanical ventilation. POCUS may have utility in patients with suspected cardiac complications of COVID-19 by excluding cardiac involvement or triggering transthoracic echocardiography or CT if POCUS imaging is insufficient. To our knowledge, this was the first study to evaluate cardiac and lung POCUS findings in relation to clinical outcomes in patients with COVID-19. The vast majority of POCUS studies were interpretable. the study was limited by being retrospective in nature with a small study population. Selection bias was relevant, as only the most ill patients with COVID-19 underwent POCUS. Larger POCUS studies of patients with different levels of risk profiles related to COVID-19 are required. This study was by Rupa L. Iyengar Kapuganti and her colleagues. The next correspondence is entitled Striking the Balance Between Safety of Patients and Team Members with Effective High-Quality Care. To the editor. During the coronavirus disease 2019 or COVID-19 pandemic, echocardiography departments have a unique opportunity to continue care for this vulnerable patient population, given that many other cardiac imaging procedures may still not be easily available. However, with continued care out comes the task of balancing the safety of team members and patients. We sought to evaluate the risk for COVID-19 transmission to our staff members who participated in direct care of patients with COVID-19 by testing for the presence of severe acute respiratory syndrome coronavirus 2 IgG antibody. Recently, our team instituted focus echo examinations with a defined safe care promise that included PPE equipment and disinfection to balance the safety of sonographers and patients. This method was published in JASE in May of 2020. 5 designated sonographers collectively performed 100 scans on critically ill patients with COVID-19 with an average in-room scan time of less than 20 minutes per examination. As guided by our safe care promise, the sonographers self-monitored for symptoms of COVID-19. None were reported during the study period. Each of these sonographers underwent a single Abbott Architect assay test for the presence of severe acute respiratory syndrome coronavirus 2 IgG antibody more than 15 days after their last scan from the COVID-19 test group. These tests were analyzed in our ACL laboratory on Abbott Architect instruments. Abbott reports a positive result sensitivity of 98.7% for more than 14 days from exposure and a negative result specificity of 99.2%. The sonographer's IgG index results ranged between 0.01 and 0.09, indicating a non-significant presence of the antibody. There was also consideration for team members who perform aerosol-generating procedures. Proper PPE equipment guidelines and a safe care promise were established and implemented to continue patient care through the pandemic. For treadmill stress echo, no patient COVID-19 testing was performed to prevent potential delays in care while waiting for results. Because the nursing staff spends the most time in the procedure room, 7 nurses from the stress lab also underwent a single Abbott Architect assay test for the presence of severe acute respiratory syndrome coronavirus 2 IgG antibody. As in the sonographer group, all tests for the nursing staff were negative for the antibody. The results from both test groups demonstrate that with appropriate PPE equipment use and focused protocols to limit exposure, the risk for COVID-19 transmission is minimal. More information regarding COVID-19 antibody test can be found through the Infectious Disease Society of America. Echo departments should feel secure in the safety of their staff while continuing care for their patient population. This study was by Denise Ignatowski and her colleagues. The next study is a brief research communication and is entitled Mitral Annular Plain Systolic Excursion, an Early Marker of Mortality in Severe COVID-19. Respiratory failure is a major cause of mortality among hospitalized patients with COVID-19. Previous studies have shown that RV dilatation and reduced RV longitudinal strain are markers of poor outcomes in this disease. COVID-19 can cause direct myocardial injury, resulting in LV systolic dysfunction and heart failure, suggesting that assessment of LV function might also have prognostic value. Reduction of longitudinal systolic function assessed by mitral annular plane systolic excursion, or MAPSE, is an early indicator of myocardial disease in various cardiac disorders. In this retrospective study, we investigated the prognostic value of MAPSE in patients admitted with respiratory failure related to COVID-19. 109 patients were admitted to the ICU at Indiana University Health Hospitals with lab-confirmed severe COVID-19, defined as oxygen saturation less than 94%, respiratory rate greater than 30 breaths per minute, and ratio of partial pressure of oxygen to fraction of inspired oxygen less than 300 millimeters of mercury, or the need for mechanical ventilation. Of these, 68 patients who underwent transthoracic echo on the basis of clinical indications were included in the final analysis. Echoes were obtained using GE S70 and E95 and Philips Epic Medical Systems ultrasound systems. Images were acquired according to a limited COVID-19 protocol, and measurements were performed per ASC guidelines. LV ejection fraction was measured using the biplane Simpson's method. MAPSI was calculated as the average of septal and lateral mitral annular excursion measured in the apical four-chamber view. 35 of these 68 studies, or 52%, had suboptimal image quality. Transthoracic echo was performed a median of 1 day after hospital admission. 66 patients, or 97%, required mechanical ventilation during hospitalization. Of these, 52, or 79%, were on ventilators at the time of echo. 22 patients, or 32%, died during hospitalization. Chi-square and Mann-Whitney U tests were used to compare clinical characteristics between survivors and those who died, as shown in Table 1. For this table, p-values less than 0.05 were considered to indicate statistical significance. I will summarize the findings from this table. Increased age, p equals 0.018, and shock requiring vasopressors, p equals 0.033, were the only variables associated with mortality. The comparison of echo variables is also shown in Table 2. From this table, it's shown that patients who died had significantly increased right atrial index volume, p equals 0.010, and lower MAPSE, p equals 0.06. There were also trends towards lower LV ejection fraction and tricuspid annular plane systolic excursion, or TAPSE, in those who died. Among lab parameters, serum creatinine was significantly higher in those who died, and this is shown in the supplemental Table 1. Multivariate analysis was conducted using binary logistic regression incorporating variable significance on bivariate analysis. Shock requiring vasopressors, MAPSE, and RA index volume were found to be independently associated with mortality. MAPSE yielded an area under the curve of 0.72 with an optimal threshold of 1.0 centimeters by receiver-operator characteristic curve analysis. The area under the curve for RA index volume was 0.61, with an optimal cutoff value of 22.6 centimeter cubed. When used in combination, RA index volume and MAPSE enable the identification of high and lower risk groups. Mortality was 77% in the presence of either reduced MAPSE, meaning less than 1.0 centimeters, or increased RA volume index, meaning greater than 22.6 centimeter cubed. Survival was 84% in those who had both preserved MAPSI and no significant RA enlargement. MAPSI emerged as the only left heart parameter independently associated with increased mortality. Other parameters of left heart size and function were not significantly different between groups, although there was a trend toward lower ejection fraction in those who died. This suggests that MAPSI may enhance the early assessment of LV myocardial injury in patients with severe COVID-19. MAPSI is a validated measure of LV longitudinal function that likely correlates reasonably with longitudinal strain. Thus, in critically ill patients in whom image quality is insufficient for accurate assessment of longitudinal strain, MAPSI may be a reasonable alternative. Additionally, RA enlargement was independently associated with mortality. In the setting of respiratory failure from COVID-19, RA enlargement may result from the combined effect of increased pulmonary pressures, RV systolic dysfunction, positive pressure ventilation, and fluid resuscitation. It is therefore not surprising that the development of RA enlargement early in the hospital stay is a marker of later mortality. Although our study did not confirm the association between mortality and RV dilatation or dysfunction, there was a trend toward lower tricuspid annular planar systolic excursion in patients who died. There has been significant effort to identify early predictors of mortality from COVID-19, including using modalities such as point-of-care ultrasound. In our study population of critically ill patients with COVID-19, the presence of either reduced MAPSI or RA enlargement was associated with high risk for in-hospital mortality, while those who had preserved MAPSI and no RA enlargement had a high rate of in-hospital survival. This suggests that in combination, MAPSI and RA size can successfully risk stratify patients with severe COVID-19 early in the hospital course and may enable early institution of aggressive therapies for high-risk patients. The retrospective nature, small sample size, and possible bias related to the selective use of echo are limitations of our investigation. Our findings suggest that the assessment of longitudinal systolic function of the left heart using MAPSI in addition to evaluation of the right heart may yield accurate information for risk stratification of patients with severe COVID-19 early in the hospital course. Larger prospective studies are needed to further define parameters that predict outcomes in patients with this disease. This study was by Amer Johri and her colleagues. That concludes this episode of the Journal of the American Society of Echo podcast. Please join us next Friday for another audio long read version of the JASE podcast. My name is Amer Johri, and I thank you once again for joining us today.